Well, welcome everybody to this session focused on COVID testing called What You Don't Know Can Hurt You, helping clients face their health fears. And we're thrilled to have some wonderful presenters here today. And welcome as well to Connecticut Coalition to End Homelessness 18th Annual Training Institute and Conference. This year's is titled Housing Equals Justice. And it's been a great conference so far. So this year's conference, I hope that those of you on, and I see that we have more people joining as we're talking right now, but this year's conference has really been spectacular. Normally we come together in Hartford with 500 people at the Connecticut Convention Center. COVID's made the world very different in many ways, and so this year, here we are together online. We were thrilled that 1,000 people from across the state and even 30 states across the country have come together. So it's through this conference. So we're really excited. This year's conference focuses on the themes of racial justice, criminal justice, and economic justice as they relate to homelessness. And we're also taking a deep dive into COVID and how it's affected homelessness and the efforts to make homelessness rare, brief, and non-recurring. So this session is a really important part of that conversation. And we hope that you're all taking advantage of the many sessions, including another one focused on COVID guidance this Friday at 10. If you're enjoying the conference or learning from it, please do spread the word on social media. Help us tell the world that housing equals justice and encourage people to register because it's not too late. We're running sessions on the hour all the way to Friday at 5. Our hashtag is ATI 2020. And we are on Facebook, Twitter, and Instagram, so you can see how you can find us and spread the word. So thanks to everybody for getting the word out so that more people are focused on homelessness, because we know that we need many people involved to end homelessness. And so we'd like to thank our sponsors. This conference is made possible by our presenting sponsors, Bank of America and Zillow. We are thrilled that our presenting sponsors made it possible for us to offer this conference free of charge to all of you. And that's why we want as many people taking advantage as possible, because that's kind of the point, is to have as many people involved in ending homelessness as possible. So thank you to Bank of America and Zillow. And I also want to send a special thanks to Connecticut Health Foundation, which is sponsoring today's workshop. So thank you to everybody at Connecticut Health Foundation for investing in making this workshop a reality. And so with that, I'm really pleased to have the opportunity to introduce some fabulous speakers. We will be hearing from Casey Harding from the Community Health Center, Jim Pettinelli from Liberty Community Services in New Haven, Linda Casey from Connecticut Coalition to End Homelessness, Tracy Burdick from Community Health Network Connecticut, and Nancy Sinkowski from Community Health Network. So we're thrilled to have all of you here today. And with that, I'd like to hand it over to our first presenter, Casey Harding. Casey, you're muted.
I'm sorry. Hi, everyone. Let's start this again. My name is Casey Harding. I work for Community Health Center Incorporated. I'm the director of our Center for Key Populations there. Just really quickly, I was telling my kids today that I had 10 minutes to give my spiel today. And so I said, wish me luck. I have to talk really fast. And my 13-year-old promptly turned to me and said, that's okay. Everything you say is boring. They won't mind if you go really quick. So that gave me a little boost of confidence for today. Just to give you a quick background on Community Health Center, we have 15 brick and mortar sites across Connecticut. We provide medical, dental, and behavioral health services at all of our sites, and we also provide specialty and support services. Along with that, we have our 8 healthcare for the homeless sites, which I oversee. They're based out of shelters, food pantries, and domestic violence shelters. At the end of the presentation, I think my contact information will be there. So if you need any information on where we are or any of the services we provide, you can feel free to reach out to me. But I'm going to jump off with a kind of an interesting little, I call this my anecdotal study because we didn't get IRB approval, so it's not publishable or anything, but I think the information is worth disseminating. If we go to the first slide, you'll see that we conducted some surveys either on paper or with iPads, and we also conducted a few focus groups. One of the things we were looking at was, on March 13th, much like everyone else, we went to completely remote medical and behavioral health services. So whereas we were spending a day or two in each shelter providing care with in-person visits, everything suddenly stopped. We wanted to decrease the footprint in the shelters, but we also had our providers working remotely. And so we conducted a little bit of a survey in our Meriden Wallingford area with CHC and non-CHC patients who had received care. We administered it on an iPad or read it to patients, and we had 55 respondents over one day. And then we also did 2 focus groups at 2 of the shelters just to get a feel. And this was really on my part a quality improvement measure to gauge the success of our telehealth, but also to see what the fears and concerns were from our patients. So we experienced some interesting little, I don't know what you call them, like one-offs on what we had normally collected as data. For instance, we normally had a 22% no-show rate, which is fairly high and higher than the health center in general. But we were kind of used to that. We saw an initial decrease in no-show rates, but then about 3 months in, we saw a pretty drastic increase again. And so we really wanted to get a feel for what patients were saying and what their fears might be and what some of the challenges and barriers they had to getting their care. So if you go to the next slide, this I found incredibly interesting. So one of the questions we asked is, if a flu shot was offered for free today, would you get it? And obviously 94% said yes. We asked if a COVID vaccine were available today free of charge, and only 16% said yes. Which was really interesting, and I'll give you a little bit of the reasoning behind that. But for the most part, that was a very clear indication that there's a lot of misinformation, concern about the truthfulness of information, and just general fear about, the newness of anything that would come out around COVID. So 84% of patients that responded to this, which I think in the end ended up being about 103, said that they would not get a COVID vaccine if it was available today. We were pleased on a scale of 1 to 5 with being extremely easy, but pretty much everybody, if they wanted a COVID test, could get one fairly easily. And that was good because at the time we were working with DPH on trying to get community testing up and running at some of the shelters, trying to work out a process for having ROIs filled out so that we could get the shelters the responses and the results and allow for desegregation and isolation and all the stuff that needed to happen along with positive COVID testing. So so that number was happy. And then as you can see, 11% just didn't want to test no matter what, no matter how easy it was, no matter how comfortable it was, they did not want to test. So on the next slide, there's a little bit more information about what the focus group, and some of these are duplicated as well. So what the focus group told us about why they were not interested in the COVID testing. And very much a common theme was that for whatever reason, they felt like they would be, if they tested positive, they would be forced into a hospital and they would get sicker. And so there was a great deal of misinformation or not, maybe not misinformation about what happens when you test positive, what happens if you end up having to go to a hospital. A lot of people had stories they were telling us about having people go to a hospital and die, even though they weren't that sick. And some people just discussed that their families were not for it, or that they felt there were implications to their housing or implications to their job that they just couldn't take a chance on. Other people really felt very confident that they didn't have symptoms, and so they didn't have it, and they didn't trust the information about, asymptomatic people testing positive. So that was really, and then as you could see, the one at the end, and we have a quote from her later: "Who will take care of my family? It's better to be sick with my family than away from them." So if you go to the next slide, we kind of drill down a little bit more on what we did to encourage testing. We really felt that the more testing we could get out to individuals living in the shelters, or even coming into the shelters to get tested, work with their fears. So make the testing as easy as possible, make it through community events and safe places. And that was a huge thing. Obviously, all the testing is done outside, so it was intense, but at least it was in a place that people felt safe. What we did in the case of some of our shelters, but also in some of our other community settings where technology might have been an issue, or where we just felt like it was a vulnerable population, we went in person to give the results and to discuss. So if there were positive cases, we sat and had a consultation with the patient and really worked through that information with them. We also did that with a lot of patients who tested negative, because we found that, first of all, we wanted them to feel really comfortable and confident getting another test later if they needed to. And we wanted them to have all the correct information. So again, we brought out a lot of providers and nurses, which typically we would have used support staff, but we used people with a little bit more medical knowledge to do phone, video, and in-person education sessions. And also conducted some counseling pre and post tests. So did a little bit of encouraging for people to get tested. And then, building up confidence, simple messaging about the importance and the impact. Again, leading by example was huge. So when we were in shelters and the staff was getting tested, it very much encouraged the residents or the individuals coming in to get tested as well. Next slide. So this is just a little bit more about telehealth. And one of the things we recognized immediately was that COVID, in order to provide the education, you have to have a means of communicating effectively. And a lot of patients initially didn't want to do video visits, especially, but even phone visits were difficult. They were used to in-person, they were used to it in a place where they had a lot of faith and trust. And so, we did try to tease out how easy the scheduling was, how easy the technology was, and really looking for some barriers that we could address really quickly that would maybe make it a little bit easier for people. So, you can see I was kind of shocked. I thought technology would be a much bigger issue. And in fact, we have at CHC, we have a very large medication-assisted treatment program, and then a very large program that works with individuals who experience homelessness. And our medication-assisted treatment program actually had a much higher rate of individuals who expressed discomfort or not having access to the technology. One of the things we realized in the focus group was that a lot of the shelters allow people to use their wireless service, whereas the medication-assisted treatment program, those individuals were expected to have their own wireless and couldn't always access it. So as you can see, how comfortable were you with having a visit over the phone? So those people who would engage in telehealth or televideo were extremely comfortable and gave a lot of positive feedback on that. 1%, I don't know how many people that was, said they weren't comfortable at all. And I think we addressed that a little bit later with some challenges that we could look at. So if you go to the next slide, I think it gives us some more information on what people expressed as barriers. And there were obviously different barriers for shelter patients and unsheltered. Not comfortable, they were afraid of being exposed to COVID. So even if we could offer an in-person appointment, they didn't want it. Not knowing who to contact, they don't like going to the doctors. A lot of people just didn't have confidence that something could be handled over the phone. Some people didn't have phones. A lot of people didn't want to use their phones. There was a significant amount of people who expressed not having a place to do visits or not wanting to talk about COVID in front of other people because that might disclose that they perhaps needed a COVID test. And then there were just people who, you know, had other stuff, had other priorities. They were transitioning to hotels. They had other priorities that they needed to work on. On the next one, we give a little bit more, on the next slide, we give a little bit more information on another subset of patients who were non-shelter patients. And, you know, we're trying to access it from home or from family members, and you know, a few of them expressed some operational issues with the technology. So not being able to get into the visit, not wanting to sit and wait for the provider. Most people who experienced the actual visit felt very confident in the care they received, and that you know, their issues got taken care of. But a lot of them really struggled with that initial either scheduling or getting in or knowing who to contact, or that kind of thing. So, and one person said they tried it and hated it and would never do it again. So as we're working to transition back to in-person visits, which we started again in the last couple weeks, what we're also working on is education around what those telehealth visits will look like. I wish that I could say I had every confidence in the world that we weren't going back to a remote world and a remote model, but the reality is that we probably are. And so we want our patients to be really prepared for what happens and how the technology will work when that happens. I know I'm out of time, but just one more slide. I think the rest of the slides are, yeah, so if you have a chance to go through these are patients surveyed, self-report an increase in difficulties around physical and mental needs. This was very much patients saying that because of COVID, they felt like their physical needs increased. And so, you know, feeling a lot of aches and pains, sleeping in different places, having to walk to different places. So they just expressed really more acute physical needs and behavioral health needs than they had previous to COVID. So that was kind of an interesting finding. On the next slide, I think we have another quote from a patient. Yeah, so we talked to them about what their physical limitations were or what they felt were the challenges. And a lot of it was directly related to the COVID isolation, you know, being distanced from family, not understanding the criteria for going into places, not having PPE. There was a lot of really fears that we all experience at the same time and are all going through right now. So, you know, I'm not sure what the perspective on this. For us, this gave us the chance to really look at our care and make sure we were providing it in a way that was as easy and seamless as possible. But it also gave us some insight into what our patients are dealing with and what their real fears are about the stigma of COVID and what would happen if they were to be diagnosed as COVID positive. And so, you know, so this will give us kind of a jumping off point for where we can innovate in the future and how we can prepare for whatever's coming next. So thank you very much. I think I kept within my time, hopefully. And I'm going to pass it off. I think Linda is next up.
All right. Thank you, Casey. That was very informative. And I am excited to share some of the research that I've done, which, since you've just talked about a survey, I'd like to share some information that I just completed this past spring, right before COVID hit, for my master's in public health degree. And I did some original research around predicting the willingness of the sheltered homeless to be screened. And I'd like to share with that information that I shared. So the next slide, please. So I'll talk a little bit what the research is and how this ties into what we're talking about today, because this information really, even though it was pre-COVID, a lot of the factors and lessons that certainly I learned from this can apply to anything moving forward. And we're certainly in a different situation now with COVID-19. But I'm going to focus on Hep C, which was the basic premise for my research. So I'll share a little bit about Hep C basics for those, and then again talk about the homeless folks experiencing homelessness and some of the risk factors that they have for this particular disease. But the survey and the research really go into some of the information that I found that are pertinent to this population. I'll share some results and some lessons learned. So the next slide, please. So just at a high level, just to make sure we're all on the same page. Hep C, as many of you know, is a chronic blood-borne liver infection, and it actually affects 71 million people worldwide, 2.5 million in the United States alone, but that number is probably low because we really truly don't know the burden because of the fact that there are no symptoms. So a lot of people who are infected actually have no symptoms. It is life-threatening without medical conditions, and there is no vaccine, but there's a very effective and very mild in terms of side effects treatment that exists. And oftentimes, people who are marginalized are the most prone to this disease, but they don't know it. So that's really the focus of what we're talking about today. We talk about health fears. Part of those fears are things that you don't actually know that you are vulnerable to. And 85% will become chronically, have a chronic condition if it's not treated. So as I mentioned, for those experiencing homelessness, we really don't know the true burden of this disease because they're not included in oftentimes the sample that we have for surveys. We estimate, so the US population, the average US population has about a 1% prevalence of the Hep C virus. But among the homeless, depending on the research that you look at, they think it ranges anywhere from 3% to 75% in this population. And some common risk factors include IV drug use, prison and being in other enclosed environments, piercing and tattoos, and having sexual partners who have HCV. Another one is blood transfusion, but that's a very low rate. So again, this population is prone for a variety of risk factors to have Hep C. And we're going to go into the next slide, which talks a little bit about the study. So this was approved by the IRB. And I did an observational cross-sectional study of 120 sheltered homeless individuals. I visited 5 shelters in 4 different cities. 2 of them were in New Haven. And I conducted a survey. There were 3 sections of the survey. One was basic demographics about the folks that they filled out. This is a paper and pen survey. And there was a quick quiz, about 10-question quiz about Hep C knowledge, what they knew about Hep C. And then a final section was about their likelihood to get screened in a variety of places or under a variety of conditions. So I'll share what that information is, and again, how it applies to what we're living in today. The next slide, please. So again, the next 2 slides are really just talking about some of the overall demographics that I found, which are completely mirroring what we find in our system, in the homeless system here in Connecticut. 49% of the folks were white that I surveyed, 27% were Black. Again, a disproportionate percentage of African Americans in my survey, which is also representative of our system in general. And for the ethnicity, 75%, 3/4 were non-Hispanic and 1/4 were Hispanic. And for the next slide, for the age and gender, men, 68% were part of the survey. Again, that's very representative of what we see in the Connecticut homeless system. And the largest percentage of folks were between 41 and 55, tied closely with 25 and 40-year-olds. So those made up the majority of folks that took my survey. But again, very symbolic of what's in the system. And for any data geeks out there, for the age I found that there was, the mean age was 43, the median age was 43, and the mode age was 43. So you have a perfect normal distribution there, which was shocking for original research. So just a fun fact there. And the next slide shows that, and these again, this just want to highlight some of the survey responses. So 42% of the folks that I had surveyed were homeless for over a year. 48% had been homeless, indicated they were homeless for less than 6 months. Over half had been to prison, and 56% said they had seen a doctor in the past 30 days. And I bring these up because these are part of the variables that I use to do analysis to predict the willingness to be screened for, in this case, Hep C. Next slide, please. So again, I'm trying to condense a whole thesis into 10 minutes, but I wanted to just highlight some of the things that are relevant. 13% of the folks that I interviewed indicated that they currently had Hep C, which is contagious, it's bloodborne, we know that, but 15% in the system of the 120 that I interviewed said they actually had it, which was interesting. And I mentioned there was the second part of the survey really talked about a quiz, a 10-point quiz. So the most known facts about Hep C, where 83% of the respondents answered this correctly, knew that Hep C can be transmitted by needles. 72.5% knew that it was highly contagious. Those are the most known facts according to my survey. The least known facts, that only 18% got this right, that there was no vaccine. People did not know that. Actually, a lot of folks in any system do not know that. And only less than a third knew that it actually affected the liver as the body part. So, and I say this because I'm building up to what people know, what they don't know, and how that affects the treatment that they're willing to get. So next slide talks a little bit more about the actual results. And so I used the variables of age, sex, education, history of prison, if they were tested before, and we talked about whether they had a doctor's visit in the past year as my variables for my multivariate analysis. And I chose age, sex, and education. Those are pretty stable, pretty reliable variables. And using the others, and had about 5 or 6 different models, depending on what I was looking at, it came out that the least likely people who said they were willing to get screened for Hep C were actually those who had been tested before. And this finding, if you kind of pause on that, that's kind of shocking, because folks, if they are at a high risk for engaging in, as we saw in an earlier slide, risky behavior, that is a troubling fact that they are, if they say, hey, I'm not willing to get screened if I've already had that. And we'll find out that that's actually not true. Matter of fact, it's very important for folks to continue to get screened for this, especially baby boomers and folks who are young, because of some of their risk factors. So ironically, or maybe not ironically, but interestingly, the most likely to get screened were those who indicated they had actually been to prison. And that could be for the fact that on day 1 of anyone's time in prison, everyone gets screened for Hep C. So maybe there's an awareness and more of an education around Hep C, and certainly maybe more of an education as to how serious it is in that. Potentially, we don't know. There's no causation here, but those are some of the findings. Again, this is highly synthesized information. So most likely and least likely people who've been to prison, least likely people who have been tested before. And from the quiz, there was a final section of the survey that talked about, asking people would they be willing to get screened in a variety of situations. And just based on those responses, the most likely to get screened were women, people aged 31 to 50. Again, this is not predicting, these are straight responses from the survey versus the multivariate analysis I just shared. But women, people between 31 and 50 years old were willing to get screened. It gets mentioned those who'd been to prison, as well as those with some college education, again, just based on the survey responses. Those who were least likely to get screened were youth, 18 to 24-year-olds, who had indicate the lowest rates to get screened. And that's troubling because of the fact that we certainly have seen the rise in opioid uses and potentially, again, that risk factor to get Hep C. As I mentioned, we saw that the ranges between 40 and a little bit over 40% of people who had been over a year in the system, in the homeless shelter system, versus under 6 months. But time didn't seem to be a factor in terms of responding to their willingness or not. So what does this all mean? Why am I talking about this today? So at the next slide, we'll talk about some of the takeaways that clearly came up from this research. Was that it's really, that the survey was an amazing tool, because we really talked about having a way to engage with this population in the shelters. And I will share that after giving the survey in these different locations, people came up to me after and said they were absolutely fascinated by this and they wanted to know more information about Hep C. I was asking all these questions and I didn't give them any answers, right? This is a survey. And so many folks came up and said, well, what is this? Am I at risk for this? And what should I do about this? So there was a factor there about having information, but not just having informational flyers as I have here, but really having that engagement and having maybe however we can engage folks who are in the system to become aware and have some kind of conversation about things that they may be at risk for. Having these targeted strategies it seems to be a key role. The providers, and by providers here I mean the medical providers, certainly can play a more active role in discussing the disease. Several folks indicated, again, over half of the folks indicated they had been to a doctor, but yet the doctor, none of them had said this was ever brought up in any session that they ever had, any visit they ever had with their doctors. So knowing that if providers can know that these folks are homeless and that they are at high risk for this, keep that conversation going. And not just have a one-time screening, but really have periodic screening for those who are at high risk. Providing convenient locations for testing is another thing that can be done in any situation. We're talking about Hep C, but this could be expanded to anything. Convenient locations for testing is critical for folks who may have transportation challenges. And again, advocating for increased healthcare insurance coverage, because there is treatment out there for a lot of this, and just making sure every state seems to have sometimes not evidence-based policies in terms of what's covered and what's not. So from a public health implication, there's a huge opportunity in front of us to decrease the prevalence of the disease and certainly gain insight into these health fears and knowledge and how that ties into the behavior that folks have. So that is my takeaway from this research, and I will now pass it on to, my contact information is on the next slide, and I will pass it on to Jim Pettinelli, who will share some information about health fears from a housing first and harm reduction perspective.
Thank you, Linda, and thanks everyone at CCEH, and thank you, Mariana, for shifting our slides, and thanks to the other panelists for being part of today's workshop. And Liberty Community Services works in Greater New Haven. We do housing and homeless services. The majority of our clients are tenants in scattered site programs or congregate living programs, apartments or shared housing. What I'm really intending to do in a really quick, high overview is just highlight some primary themes around housing first and harm reduction. Slide. And really look at, how these elements really inform our current practice and hopefully influence best practice moving forward during the pandemic. Slide. So, just looking at some of the housing first principles, just two elements that really pop right out related to the times that we're currently living in, number 3 and number 5. Robust services come to the housing. Services are predicated on assertive engagement, not coercion. And I just want you to focus on assertive engagement. And then number 5, from a harm reduction approach, a really key element to housing first. Everyone deserves the opportunity to pursue, a healthy and productive life, and it all starts with housing. Research years ago, specifically around AIDS housing, clearly defined that housing is healthcare. The outcomes were very clearly connected. And I think that those elements really speak to us in today's times. Slide. So just from the harm reduction perspective, the basic principles, valuing the individual, reducing stigma and judgment, and mitigating the potential harms that individuals may experience. And then that last bullet, refocusing the conversation into finding the relationship a client has to their substance or behavior. Remember, a negative coping strategy is still very much a coping strategy. And it's about establishing that relationship with people and really valuing them, supporting them, reducing stigma and judgment, and then starting to work towards mitigating those potential harms. Slide. Every problem was once a solution, recognizing that people are coming from a perspective where they started using or they started behaving in a certain way to relax, to calm down, to cheer up, to feel more connected, to feel worthwhile. And just having that perspective inform our work with folks, connecting them. Slide. And this is just really about, healthcare and harm reduction and what that connection is. And when we stop and think about harm reduction, we often think about naloxone or overdose education, syringe services programs, safe injection, consumption sites. Slide. And what I really think we want to be looking at is expanding how we think about harm reduction. And that it does very much assist us in focusing people on linkage and connection to healthcare. Safer sex education, condoms, PrEP, COVID-19 testing, linkage to primary care, low threshold housing, flu shots, face masks, physical distancing. All of these elements are about risk reduction, risk management, and they all are key elements to working with people at mitigating harm in their lives. So thinking about linkage to care. Understanding barriers, implementing and coping interventions. I think we have to start and really think about stigma, racism, and classism, and to really start to think about how people's past experiences or their perception around past experiences really do impact how they engage in services. And in the past, many people have experienced sharing certain medical information or behavioral health information as limiting access to services, and the issues that people have around trust and mistrust. And I think that we have to have this perspective when we're working with people, linking them to care, and in a particular way, when we're thinking about COVID-19, because many people connect sharing information or being associated with potentially being at risk around COVID or going to get a test could potentially limit their access to housing or other services. So that is a barrier. How do we work with people implementing coping interventions around that? Slide. Trauma-informed care, just really understanding the previous slide and coming from the perspective and understanding the impact of violence and victimization and how that has really impacted people's choices. 4 quick assumptions. Trauma is central and pervasive. Use universal precautions. Symptoms and behaviors are attempts to cope. And the goal is to work with people around the return of a sense of autonomy and control for that person being served. Many of these things, are understandings that I know you all have and are practicing today around harm reduction, housing first, trauma-informed care, but I think they have become more centralized than ever before because of the impact of the pandemic on our work and our clients. Slide. So trauma-informed care, I want to just come back to that assertive engagement piece, establishing a safe environment with people, using an empowerment model, supporting the development of healthy relationships, and building coping skills, providing access to trauma-specific services, and they all need to be holistic. Slide. So these are going to really be critical for pieces that I see that are important for Liberty Community Services and what we're learning related to how we're defining our current practice with our clients and our tenants. And it really does need to be about welcoming, and working with individuals who are coming to our services and programs because they have serious challenges and obstacles, and they have experienced serious challenges and obstacles in accessing services. And we should expect challenging behaviors, uncertain and changing motivations for change, difficulty with relationships, difficulty with authority. But this is who we work with. And we really need to have the best understanding of where people are coming from. Slide. So welcoming and collaboration. And these are the really primary points for me. Building a relationship with the full participation of the individual that we're serving. The work and healing takes place within that relationship. And individuals come with their own unique strengths, skills, and wisdom, and we would be wise to make as much use of their experience as our own, and sometimes more of their experience than our own. And what we're really seeing more and more each day is that very innovative engagement of people is critical. Establishing those relationships with people is more important than ever before. And there are many things that we as providers in the housing and homeless services field can provide remotely. There is a critical need for on-site capacity and on-site relationships with people to really work with them. Telehealth, teleservices is a phenomenal tool, and it works for many, many people. But sometimes case managers, coordinators need to be on site to really create the opportunity for those linkages to happen, whether it be setting up computers for them to access, a safe environment for them to sit and have those teleservice appointments, or sometimes even using the case manager's phone to make that teleservice link happen and guiding them through that process. Slide. This is just a quick quote from Pat Denning, who is a phenomenal harm reduction specialist. And it's just requiring that, we place our clients' perspectives and their wishes above our own sense of what is best. We ask ourselves to set aside our own fears, values, choices in order to assist this human being to make his, her, or their own choices and grow in his, her, or their potential in the midst of chaos. And these are chaotic times, and those that we are serving have experienced that chaos, and we need to be there for them. And thank you very much for inviting me to be here today. Thanks. I'm going to introduce Nancy and Tracy.
Okay. Hi, thank you, everyone. Thank you, CCEH, for inviting us to participate in this really important topic and allow us to talk a little bit about how we support our Husky members during this pandemic and work with that fear of all these things that are going on in their lives that they have little control over. And I have with me today Tracy Burdick, who is one of our certified community health workers. And Tracy will talk a little bit about her role in supporting our members, as well as her data, maybe an example of a case that she's worked with. So next slide, please. So we're here from Community Health Network. We are of Connecticut. We are part of the Intensive Care Management Program. So for those of you that don't know too much about us, we are the Administrative Service Organization, or the ASO, for the state of Connecticut, and we manage the medical portion of Husky Health. So the ICM program is a free and voluntary program that works with members who have Husky Health to be able to reach their health goals through education and really access to quality health care. And we do that through a very person-centered approach. We work individually with each member to figure out what are their needs, what would they like to accomplish, and then work together to make those things happen. So we have an interdisciplinary team. We have nurse case managers, some of which who specialize in chronic diseases such as diabetes, asthma, COPD, CHF, sickle cell. And to just follow up with what Linda had talked about, we do have some staff who support members who are taking hepatitis C medication. And this team works together because we know that people that have complex needs and a lot of barriers really then have a higher risk for poor health outcomes. So we work with them individually to try to minimize those obstacles. And we use a very thorough, culturally sensitive, person-centered approach to make that happen. So next slide, please. So these are just some of the factors that impact health. Most of them I think you're all aware of: cultural, behavioral, environmental, financial, social determinants, as well as their physical and medical concerns that affect their health every day, and how important it is to address all of those pieces and look at our members holistically to make sure that we're working on all those pieces to reach their goals. Next slide, please. So this is our interdisciplinary team. So we have nurses at all different levels. We have dietitians, we have a pharmacist, we have certified community health workers, we have some specialists. We have certified diabetes educators, certified case managers, lactation specialists, childbirth educators, along with our licensed clinical social worker, a licensed marriage and family therapist, our administrative care coordinators, and our medical director. Next slide, please. So one of those interdisciplinary members is our certified community health workers, and they're a part of our community engagement team. So I'm going to introduce Tracy to tell you a little bit about what she does every day for Husky Health members.
Hi, good afternoon. I just want to say thank you so much for having me. I am one of the 17 certified community health workers. We are frontline workers who empower families to improve their health, and we help members access community resources to stabilize their living situations. We help them navigate through the healthcare system and manage chronic conditions in culturally relevant ways. So I wanted to take a moment to just highlight a case I worked through out this pandemic time. The case entered in as the opening of the pandemic in March. It was a mother of 3 young children. She was diagnosed with COVID-19. She was quarantined at the time, which was new for our understanding of what that looked like. She was not only very ill, but very anxious and fearful of the unknown. She was alone with no food, no way to get food, and the food supply within her town was very limited. She had, at the time, a truck driver, a husband that was a truck driver, who was hauling DME to New York City. If you recall the increase in COVID cases during that early time, he was one of those truck drivers getting those DME products and supplies to New York City. So during that response, I was able to reach out to local agencies to no success, because most of them, their staffs were pulled to be work at home. So those were all unsuccessful. And then I ended up reaching out to the local fire department, which an official from there brought actually a box of food from his own home, and other needed items such as diapers and wipes for the mother, and left them at her front door. So that was very much a help. And then the local neighbors and teachers of their kids stepped in and was able to bring some food, books, and other needed items just to keep the kids busy. But I followed up after that, and that helped them for the time. But I followed up in August, and come to find out, the member conveyed that she and her husband were diagnosed with COVID-19. She was very, very overly anxious during the call. They had no income. They were financially in duress. She didn't know what to do. They were facing an eviction. And the landlord throughout this early time of the pandemic was very patient with the family, but then began to press in and cause pressure, threatening eviction. And so the member was very anxious about that, and really didn't know what to do, how to get some financial supports. So what I suggested was, at the time, there was I believe it was called the TRHAP, the Temporary Rental Assistance, Housing Assistance Program, and that was able to help them during the time. And by the end of the call, we were actually both laughing, and I was able to ease her of her anxiousness and her fears. So I kind of rushed through that case because of time, but I just wanted to highlight that and bring that to you all, just to highlight the just focusing on the barriers of our members and trying to overcome their barriers with the local resources, which it was a successful visit, case visit for me. So I just want to say thank you for letting me share that. And next slide, please.
Okay, so as the ICM team, we work to outreach to our members. So most of what we do is by phone, but we also, prior to COVID-19 or the pandemic, we were out in the community. So we were out doing face-to-face visits. And that could be visiting them at their shelters, at their soup kitchens, at hospitality centers, at WIC sites, as well as sometimes going to physician or provider visits with them to really help give an explanation of what that person was looking for to get from their provider if they had trouble understanding or communicating those needs. We've also always been doing video conferencing. It seems to have taken off a little bit more now that there's so much telehealth going on as well, and I think our members do appreciate being able to see us face to face, especially during this quarantine time. Next slide, please. So changes that we've had to make due to the pandemic. We had been out in the community really working with our members, so we've had to suspend some of those face-to-face visits with our members, as well as the in-person visits with them to their providers. We have not been able to go to some of the soup kitchens and shelter visits that we had to reach our members who may not have phones or may not have minutes on their phone or data to be able to do video conferencing with us. But the things we have been able to continue to do, we do participate in a number of the community care teams around the state. So we did that by virtual connection to stay in contact and try to help where we could for those members. We still continue to reach our members by phone and video conferencing when we were able to, and then collaborate, of course, with all their service providers. Next slide, please. So some of the things that our focus had to change for during this time was really to help our members during, especially early on in the quarantine period and when providers were closed and they weren't able to access their medical care. So we work to facilitate communication with their providers, especially when the practices were closed, to try to reach someone to help them in the practice or find them another area they could go to get the care that they needed. We work to identify open offices that could provide telehealth or in-person visits when that was necessary. We really encouraged our members to communicate first with their providers to find the safest facility, especially when they had emergent needs. And we really didn't know who was open and you know, so many people were in the emergency room with COVID and members were afraid to go. And then we really worked hard to keep up with resources. You know, what resources were open for food, had facilities, providers who were willing to accept new patients who didn't have an established relationship already. And that was really thankful for 211 to help keep us up to date with some of those and to be able to communicate that with our members. Next slide, please. So what were we able to do for our members who have unstable housing? We refer them to our community health workers like Tracy. We were collaborating early on with our shelter personnel to help our members, providing resources for all their social determinants of health, especially when things had moved or changed or closed. If our members were having behavioral issues, and we know that there has been some increase in some of the behavioral health concerns for our members during quarantine, that we were able to do warm transfers to, for example, a crisis line at Beacon Health Options. We work to connect them to their behavioral health providers and work to help them set up telehealth visits if that was possible. And we tried to stay in contact with them as much as possible to give them that support. So here is just some contact information for Tracy and myself. Certainly we can take any referrals that you think we can help with. They do need to be Husky members, and or they can always call the number on the back of their insurance card to get to our member engagement, who can put them over to us for a referral. Thank you.
If there are no questions, we can just show the final slide, please. Well, the final slide, in absence of seeing it, I can tell you, we encourage you to, if you have additional sessions you'd like to go attend that are posted on our website, feel free. Registration is still open. The conference is going every day, 9 to 5 until Friday, so several more days left. And we encourage you to continue to keep watching and follow us on social. Our hashtag is ATI2020, as you can see on the screen. And I know many of you may be gearing up for the next session, which is about municipal workshops. So thank you all for your time. Thank you for all the panelists for sharing your information. This has been very exciting. And we look forward to hearing from everyone, and have a great day. Thank you.